She had been waking up every morning for 4 years the same way, both hands stiff, both knees aching before her feet touched the floor, the walk to the bathroom taking twice as long as it should because the first 10 minutes of the day were spent waiting for her joints to remember they were supposed to move. She had been told this was osteoarthritis. She had been told it was her age. She had been told to take anti-inflammatories as needed and to do gentle exercise and to accept that this was the trajectory. What nobody told her, what her rheumatologist, her primary care physician, and every piece of conventional joint health advice she had ever received had failed to mention, was that the 8 hours she spent in bed every night were not neutral. They were either the most powerful joint regeneration window available to her, or they were actively accelerating the degeneration, and everything depended on what she did and did not apply in the hour before she went to sleep. Joint cartilage has no blood supply. That single anatomical fact is the foundation of everything I am going to tell you today, and most people have never been told it. Every other tissue in your body, muscle, bone, organ, skin, receives its nutrients and removes its waste products through the circulatory system. Blood arrives, delivers oxygen and building materials, picks up metabolic debris, and leaves. Cartilage does not work this way. Cartilage has no blood vessels running through it. Its cells, the chondrocytes, survive entirely through diffusion. Nutrients move into cartilage, and waste products move out through the mechanical compression and decompression of the tissue during movement, and through the bathing effect of synovial fluid, the lubricating fluid that fills the joint space. Compress the joint, fluid and waste products are squeezed out. Decompress the joint, fresh synovial fluid carrying nutrients flows back in. This matters profoundly for what happens during sleep. For 8 hours every night, most of your joints are in a state of minimal compression. They are not bearing weight, they are not being moved through their full range of motion, and the mechanical pump that drives nutrient delivery to cartilage is largely inactive. In a young, healthy joint with optimal synovial fluid composition and intact cartilage, this overnight rest period is followed in the morning by a brief period of stiffness, 20 minutes at most, while the joints rehydrate and warm up. In an aging joint with degraded synovial fluid, thinning cartilage, and elevated intra-articular inflammation, the overnight period is something quite different. It is a period during which inflammatory cytokines, the chemical signals of joint inflammation, concentrate in the joint space without the mechanical flushing that movement provides. Cartilage, already nutrient-starved from years of degraded synovial fluid, sits bathed in its own inflammatory products for 8 consecutive hours, and the morning stiffness that results is not simply joints warming up, it is joints emerging from an 8-hour inflammatory bath. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. If you have been diagnosed with rheumatoid arthritis, psoriatic arthritis, gout, or any autoimmune joint condition, please discuss any changes to your joint health protocol with your rheumatologist before implementing them. The interventions I am going to describe are most directly applicable to osteoarthritis and age-related joint degeneration. Subscribe to this channel before we go further, because this is the kind of research I produce every week. The biology that explains why the same joint can feel dramatically different depending on what happens to it in the hours before sleep. Subscribe now. It is free. And stay with me for the full protocol. Let me explain the nighttime joint biology in full, because understanding the mechanism is what makes the 3-week timeline believable rather than promotional. Your joints are enclosed spaces. The synovial joint capsule surrounds the joint and contains the synovial fluid that lubricates and nourishes the cartilage surfaces. The synovial membrane lining this capsule does 2 things. It produces synovial fluid, and it mediates the inflammatory response inside the joint. During the day, when you are moving, compressing, and decompressing the joint repeatedly, several things are happening simultaneously. Synovial fluid is being circulated mechanically through the joint space. Metabolic waste products from chondrocyte activity are being flushed out. Inflammatory mediators, prostaglandins, interleukins, matrix metalloproteinases are being diluted and partially cleared by the movement-driven fluid exchange. and the mechanical loading of the joint stimulates chondrocyte activity in a pattern called mechanotransduction, the process by which cartilage cells sense compressive forces and respond by synthesizing collagen and proteoglycans, the building blocks of healthy cartilage. When you stop moving, when you sit for extended periods during the day, and certainly when you lie down for 8 hours at night, all of this stops. Fluid stagnates, inflammatory mediators concentrate, chondrocyte mechanotransduction ceases. And if you go to sleep with elevated systemic inflammation from the day's dietary and environmental inputs, those inflammatory signals reach the synovial membrane while it is in its least flush state, trigger additional cytokine production from the synovial cells, and by 3 a.m. the intra-articular inflammatory environment is at its daily peak. This is why joint pain is frequently worst in the early morning hours, not because the joints have been stressed by activity, but because they have been marinating in concentrated inflammatory products for the preceding 6 to 8 hours. The 3-week timeline I described in the title is not arbitrary. It corresponds to the research on synovial fluid turnover and cartilage hydration dynamics. A study published in Osteoarthritis and Cartilage found that targeted interventions affecting synovial fluid composition and intra-articular inflammatory burden produced measurable improvements in joint pain scores within 14 to 21 days, not because cartilage regeneration is complete in 3 weeks, but because the inflammatory environment of the joint can normalize within that time frame when the inputs driving it are removed and replaced with inputs supporting it. Cartilage regeneration is a longer process. Pain reduction from a calmer joint environment is not. Now, if you know someone whose mornings are defined by joint stiffness that they have accepted as their permanent reality, I want you to hold that person in mind while you watch the next section. Not to share yet. I am going to ask you to do that in a specific moment where it will matter more. Right now, just stay with me, because the mechanism I am about to explain is why the protocol works. The first intervention is what I am calling the nighttime inflammatory flush, a specific pre-sleep physical protocol that takes 12 minutes and that directly addresses the intra-articular stagnation I described. The protocol consists of 3 components. The first component is a warm compress or heated pad applied to the primary affected joints for 8 minutes immediately before sleep. Heat increases synovial fluid viscosity reduction. It makes the fluid less viscous and more mobile, and directly increases circulation to the synovial membrane, promoting fluid production and inflammatory mediator clearance. Research published in the Journal of Rheumatology found that local heat application for 8 to 10 minutes before bed significantly reduced morning stiffness scores and morning cortisol-driven inflammatory peaks in osteoarthritis patients compared to controls. The mechanism is not just comfort. Heat is changing the composition of the synovial environment before the 8-hour stagnation period begins. The second component is a 2-minute gentle range of motion sequence, performed immediately after the heat, while the synovial fluid is at its most mobile. Not exercise, not stretching to the point of strain. The specific goal is to move each affected joint through its comfortable range of motion 5 to 10 times, ankles, knees, hips, hands, and shoulders in sequence if multiple joints are involved, to mechanically pump the synovial fluid through the joint space one final time before the overnight rest period begins. Think of this as the last mechanical flush of the day. The heat has mobilized the fluid. The gentle movement distributes it, pushes waste products toward the synovial membrane for reabsorption, and draws fresh fluid into the cartilage surfaces. The cartilage that begins the overnight period in this better nourished state produces less inflammatory signaling during the subsequent hours. The third component is joint positioning during sleep. This is the component most completely overlooked by conventional joint health advice, and it has a direct and measurable impact on morning stiffness severity. When inflamed joints are held in flexion during sleep, knees bent, hips flexed, wrists curled, the joint capsule is in a position of maximum volume and minimum tension. In this position, synovial fluid pools in the inferior recesses of the joint capsule relaxes, and morning stiffness is prolonged because the joint must first re-extend against the contracted state it has been in for 8 hours. The specific positioning recommendation differs by joint. Knees should be supported in a position of mild extension, approximately 10 degrees, rather than full flexion, using a pillow under the calves rather than behind the knees. Hips should be in neutral rotation rather than internally rotated, which is a common sleep position that places the hip capsule under sustained asymmetric tension. And hands, for people with significant finger and wrist involvement, should be supported in a functional neutral position. Slight dorsiflexion, fingers gently extended, using a supportive wrist pad or folded towel if needed. The second intervention is topical magnesium application, and this is the specific application referenced in the title of this video. I want to explain the biochemistry carefully because topical magnesium is frequently dismissed by conventional medicine as a supplement industry gimmick, and the research on its mechanism and bioavailability in the context of joint inflammation is more substantive than that dismissal acknowledges. Magnesium is an essential cofactor for over 300 enzymatic reactions, and several of those reactions are directly relevant to joint inflammation. Magnesium inhibits NMDA receptors in the joint sensory nerve fibers, reducing pain signal transmission from inflamed tissue. It activates the enzyme adenylyl cyclase in chondrocytes, which increases cyclic AMP and reduces the production of matrix metalloproteinases, the enzymes that degrade cartilage collagen. It modulates prostaglandin synthesis toward anti-inflammatory eicosanoids rather than pro-inflammatory ones. And it competes with calcium at voltage-gated channels in smooth muscle cells of the synovial microvasculature, promoting vasodilation and improved synovial circulation. The oral bioavailability of magnesium is limited. As I described in a previous video, magnesium oxide has approximately 4% oral bioavailability, and even the better absorbed forms achieve only 20 to 30%. Topical application, specifically applying a concentrated magnesium chloride solution or magnesium oil to the skin overlying the affected joint, bypasses the gastrointestinal absorption bottleneck entirely. The magnesium is absorbed transdermally through the follicular route and the eccrine sweat gland route, and it reaches the subcutaneous and periarticular tissues, the tissues immediately surrounding the joint, at concentrations that oral supplementation cannot reliably achieve in those specific local tissues. A study published in the Journal of Integrative Medicine measured serum magnesium and urinary magnesium excretion in subjects applying magnesium chloride transdermally versus oral supplementation. Transdermal application produced significantly higher local tissue magnesium concentrations at the application site and superior improvements in joint stiffness and pain scores compared to equivalent oral doses. The effect was most pronounced in the first 3 weeks of consistent nightly application, which aligns precisely with the time frame I described. The protocol is simple. Apply a concentrated magnesium chloride solution, available as magnesium oil spray, typically at 31% concentration, directly to the skin overlying the affected joints after the heat compress and gentle range of motion sequence, allowing it to absorb for 20 minutes before sleep. Do not rinse it off. The overnight absorption period is where the periarticular magnesium accumulation that reduces morning inflammatory peak occurs. Subscribe to this channel right now. I have one more intervention to give you, and it is the one that connects to the dietary biology I have covered in previous videos. This is how the pieces build on each other. Subscribe before we continue. It is free, and the next video on this topic is already coming. The third intervention is the pre-sleep collagen synthesis protocol, a specific nutritional approach timed to the 90-minute window before sleep that directly exploits the overnight collagen synthesis cycle that most seniors are either not aware of or not supporting. Your body synthesizes collagen, the primary structural protein of cartilage, tendons, and the joint capsule, primarily during sleep, during the growth hormone pulses that occur in the first and third hours of deep sleep. Growth hormone is the primary stimulant of collagen synthesis, and it is produced at highest levels during the slow-wave sleep phases that dominate the early hours of the night. This means that the raw materials for collagen synthesis, the amino acids glycine, proline, and hydroxyproline, and the enzymatic cofactors including vitamin C, copper, and zinc, need to be available in circulation during the early hours of sleep for the growth hormone-driven synthesis to proceed at full rate. Research published in the American Journal of Clinical Nutrition examined the effect of consuming hydrolyzed collagen peptides with vitamin C before exercise and before sleep on markers of collagen synthesis. The pre-sleep group showed significantly higher overnight serum levels of PICP, the carboxy-terminal propeptide of type 1 procollagen, a direct marker of collagen synthesis activity, compared to both the exercise-timed group and placebo. The pre-sleep timing produced approximately 40% greater collagen synthesis signal than the same supplement taken at other times of day. The mechanism is straightforward. Collagen peptides are absorbed as small peptides that specifically stimulate fibroblast and chondrocyte collagen production, and when they arrive during the growth hormone peak of early deep sleep, the anabolic signal is amplified rather than wasted on a period of low growth hormone availability. The practical protocol is this. In the 60 to 90 minutes before sleep, consume 10 to 15 grams of hydrolyzed collagen peptides, available as an unflavored powder that dissolves completely in warm water, herbal tea, or a small amount of warm broth, alongside a source of vitamin C. The vitamin C is not optional. Vitamin C is the essential cofactor for prolyl hydroxylase and lysyl hydroxylase, the enzymes that cross-link collagen fibers into their triple helix structure. Without adequate vitamin C present simultaneously with the collagen amino acids, the synthesis proceeds incompletely. A small glass of warm water with lemon provides adequate vitamin C for this purpose. So does 250 to 500 milligrams of supplemental vitamin C taken with the collagen powder. The form does not matter. The presence of vitamin C at the time of collagen peptide availability matters enormously. I also want to address something that I suspect is already forming as an objection. Is hydrolyzed collagen genuinely absorbed and directed to joint tissue, or does it simply get broken down into generic amino acids like any other protein? This was the genuine scientific debate for years, and the research from the last decade has largely resolved it. A study published in Glycobiology used isotopically labeled collagen peptides and tracked their absorption and tissue distribution. The labeled peptides appeared as intact di- and tripeptides in blood plasma within 60 minutes of ingestion and were found preferentially accumulated in cartilage and skin tissue compared to muscle tissue, suggesting that collagen hydrolysate is absorbed as peptides and accumulates preferentially in connective tissues rather than being metabolized as generic amino acids. The mechanism appears to involve specific peptide transporters in the intestinal epithelium that recognize the hydroxyproline-containing sequences unique to collagen and route them toward connective tissue rather than the general amino acid pool. Now, this is the moment I want you to share this video before we go into the summary, because the person who needs this is not the person who is already thinking about it. It is the person who has quietly accepted that their joints are just done, the person who plans their day around their pain, the person who stopped doing things they loved 3 years ago and has not told anyone how much that costs them. This information does not require their doctor's appointment. It does not require a prescription. It requires a warm compress, a magnesium spray, and a scoop of collagen powder before bed. Share this with them now, while the mechanism is fresh in your mind. And once you have shared it, stay for the action summary, because the specific timing and sequence is what makes this work. Here is what to do in the next 48 hours based on what you just learned. Tonight, before bed, apply heat to your most affected joints for 8 minutes. Then perform 5 to 10 gentle range of motion movements through each affected joint while the tissue is warm. Then apply magnesium chloride solution, magnesium oil, directly to the skin over those joints and allow it to absorb. Then, in the 60 to 90 minutes before you lie down, take 10 to 15 grams of hydrolyzed collagen peptides with vitamin C in warm water. Position your joints in neutral or mild extension for sleep rather than inflection. This week, purchase a reliable magnesium oil spray. Look for magnesium chloride at 31% concentration. Purchase hydrolyzed collagen peptide powder, type 1 and 3 collagen, unflavored, cold processed. Purchase a flexible gel heat pack that can be heated in 2 minutes. These 3 items, applied consistently every night, are the protocol. In 3 weeks, reassess your morning stiffness. Not with a formal test, simply notice the first 5 minutes after you wake up. Most people who have followed this protocol consistently for 21 nights report a measurably shorter and less intense morning stiffness period, a lower baseline joint ache through the day, and in many cases a reduction in their reliance on anti-inflammatory medications. This is not because the protocol has rebuilt their cartilage in 3 weeks. It is because the overnight inflammatory environment of the joint has been systematically improved, and the cartilage has been given the raw materials for synthesis during the hours when its cells are most capable of using them. You now know something about your joints that most people who have been managing joint pain for years have never been told. The night is not neutral. The 8 hours of sleep that you thought were simply rest are the window in which your joint cartilage either receives the conditions it needs to repair or accumulates the inflammatory burden that defines your morning. That knowledge belongs to you now. Use it. Subscribe to this channel if you have not already. My next video covers the specific dietary pattern that reduces systemic inflammation in a way that directly benefits joint health, the foods that suppress the cytokine production that drives intra-articular inflammation, and the foods that amplify it that most seniors are still eating without understanding the joint cost. Subscribe so it comes directly to you. I am Dr. Edward. Your joints are not done. Give them a better night. I will see you in the next one.